So now we will move on to the HIV-exposed infant. Okay, so let's move on to a question. A 24-month-old little boy comes to your office for diagnostic testing because his mother was recently diagnosed with HIV infection. His mother is 23 years old and she received extensive prenatal care. She had a non-reactive HIV antibody test at the start of her pregnancy. You examine the child and note a normal exam, including developmental and growth parameters. You decide the best course of action is to A, provide reassurance, citing the mother's previously negative test and indicate there is no need to do further HIV testing. B, recommend obtaining a DNA PCR on the child. C, recommend obtaining a fourth-generation HIV test on the child. D, recommend obtaining an HIV Western blot on the child. Or E, check a CD4 count, and if abnormal, get an HIV-specific test. So the correct answer is to obtain a fourth-generation HIV test on the child. So let's go through why this answer is correct and the others are not. So this kiddo is over 18 months of age. So what we know is that, let's say that mom was infected with HIV in pregnancy, which is definitely possible. She only had a first trimester HIV test done. So that means that any time during her pregnancy, she could have potentially become infected. So if that's the case, we know that maternal antibodies as transplacentally crossed can remain positive in children up to around 15 to 18 months of age. And so generally, we do not recommend an antibody test prior to then. We always do DNA PCRs in younger children, especially children less than 15 to 18 months of age. However, in this case, this kiddo is 24 months old. And so the fourth generation test, which includes an antibody and antigen on the test, is an appropriate test because he is over the age of 18 months and he should no longer have maternal antibody, thus causing a false positive. Just anecdotally, in my own practice, I have received a few calls before from providers who were very concerned because there was a history of maternal HIV and they tested the neonate with an antibody test and it came back positive. And so I got to be the bearer of excellent news and say, hey, that antibody test probably is maternal antibody and it probably has nothing to do with the baby. And most likely this baby is not infected because the mother was well controlled. So remember, we do PCR on the baby in those first 15 to 18 months of life. And after that, we can do an antibody test like this rapid fourth generation HIV test. Okay. And then DNA PCR would be correct if this was a neonate or a child under the age of 18 months. So the way that HIV has progressed since it was really bad in the 80s and 90s is truly amazing, and particularly perinatally acquired HIV. So on the y-axis, you can see the number of cases, and on the x-axis here, you can see the years since the beginning of the HIV epidemic. And this is a lot of cases of perinatally acquired HIV, especially with the severity of infection that can occur in neonates. And you can see, based off of different interventions we've had, which we'll go through, this really amazing drop in the number of cases of babies diagnosed with HIV. So how do babies become infected with HIV? And the answer is multiple different ways are possible. We know that with no intervention at any stage, the risk to the baby of acquiring HIV is about 30 to 45%. So that's almost that's a third to a half of babies become infected without intervention. So a third of those babies become infected antepartum, so in utero, transplacentally. A third become infected intrapartum, so during labor and delivery. And a third become infected in infancy, secondary to breastfeeding. With intervention at each of these stages, transmission is less than 1%, which is really amazing. So let's talk about these 3 pillars of prevention, because each of these things are why we've been able to prevent perinatal HIV infections. So antepartum, a big one is maternal HIV testing. All women should be tested in the first trimester. Third trimester testing is recommended in high-risk situations and geographic locations. I live in Louisiana. All of Louisiana is considered to be a high-risk geographic location. So it is recommended in all of Louisiana that all women should receive third trimester HIV testing. And of course, there's other states with similar situations and others that are less risk for HIV. Women with unknown or undocumented HIV status or with HIV testing not performed in the third trimester despite recommendations should have a rapid HIV test performed at the time of labor. So in my hospital here, it is fairly typical for women to come in and just get a rapid HIV test upon presentation for labor and delivery. Maternal antiretroviral therapy. So let's say that this testing was done and a woman is HIV positive, either prior to pregnancy or during pregnancy acquires it. So if you're dealing with a patient who has been living with HIV and they become pregnant, in the vast majority of cases, you just continue their current antiretroviral therapy, assuming it has been effective for them. The most important thing to decrease transmission is to have a regimen that works for the pregnant woman who's been taking it and she knows it works for her. She doesn't get a ton of side effects, so she's not going to be throwing it up and getting poor drug levels. You want her to be taking something that she knows works. So if it's not a new diagnosis and she's been on it, just keep her on it. If it's a new diagnosis in pregnancy, this is one of the highest risk situations because we know with new diagnosis that you get this really, really, really high viral load before your T cells kick in and they drop that viral load down. We know that the higher the viral load, the higher the chance of infecting the infant. So this is automatically a high-risk situation. Those women should be started as soon as possible on a regimen that is preferred in pregnancy. And then we do monitor women much more closely during pregnancy for HIV viral loads. So what tests do we use? In general, we use the 4th generation rapid antibody antigen test. So all of these names are sort of the same. 4th generation just means that this is the 4th generation of the test, and it includes both it includes, I'm pretty sure, both IgG and IgM, but then it also includes an antigen, which allows for detection much earlier. So if acute or recent HIV is suspected, like really acute, then an HIV PCR should be ordered because there is what's called this eclipse period right here where neither the antigen nor the antibody are going to be positive. Actually this whole section right there. And so you may actually miss an acute HIV diagnosis. So in that case, a PCR should be ordered. So intrapartum, so this means during labor and delivery, what do we do? So it really depends on how well-controlled mom is. So let's say that mom is super well-controlled. She has less than 1,000 copies per mil. Some experts will go even lower than that. but within 4 weeks of delivery. So she's had a viral load recently, and it shows she's well controlled. She's been well controlled. She's taken her meds. She's good to go. So we do not recommend zidovudine in those cases. If the HIV is essentially undetectable, less than 50 copies, or the receiving ART, antiretroviral therapy, and they're adherent. We do consider zidovudine if it's between 50 to 1,000 copies per mil. And I would say that most experts I'm aware of would probably give zidovudine in that range. And then scheduling a C-section for these women is not recommended for the purposes of preventing HIV transmission, just because we're not clear that it actually helps all that much. Now, the situation is different if this woman has greater than 1,000 copies or has unknown HIV RNA within 4 weeks of delivery. You absolutely do zidovudine, and you do delivery by C-section, which is scheduled at 38 weeks. Now, if rupture of membranes occurs prior to a scheduled C-section, the data is insufficient to really provide a recommendation whether you should just go ahead with the vaginal delivery or go ahead and do a C-section. Okay, so we talked about prevention antepartum. We talked about prevention during labor and delivery. So now let's talk about prevention in infancy. So the first thing is looking at breastfeeding or chest feeding. So HIV used to be in the United States, until very recently, an absolute contraindication for breastfeeding. However, this has changed. Recent guidelines encourages counseling and shared decision-making as long as mom is very, very controlled. So maternal viral load is sustained undetectable. She does an awesome job of taking her meds. Her viral load is undetectable. And then you can also consider the use of infant prophylaxis for the duration of breastfeeding. Okay, so what about infant antiretroviral prophylaxis? So every baby born to an HIV-positive individual receives postpartum antiretroviral drugs to reduce the risk of HIV transmission. And you want to start this as soon as possible, generally within the first 6 hours of delivery. So every baby is going to get some sort of a regimen, no matter how well controlled mom is. However, the regimen is going to really be dependent on what the risk factors are. So if it's a low-risk scenario, baby's not premature, mom was not infected during pregnancy, and she has maintained really good control of her viral load, and she has a really low viral load at or after 36 weeks, this is considered all low risk. Excuse me. High risk is defined as an infant born to a person with any of these risk factors. They have not received antepartum antiretrovirals. They have received only intrapartum antiretrovirals, so meaning just zidovudine during labor. They received antepartum antiretroviral drugs, but they were not able to achieve viral suppression, or they had primary or acute HIV infection during pregnancy. So remember, I said that risk is super high for women who have primary infection during pregnancy. Okay, so this is amazing. Infants who fit the low risk category, this was recently changed from 4 weeks to 2 weeks. So they only need 2 weeks and only have one drug, which is zidovudine. And zidovudine is also called AZT. You may have heard it called that way. Infants who fit this category of high risk, because we know that suppressing that viral load as soon as possible has a long-term impact for the overall health of the infant, if they're in a high-risk category, we just presumptively treat them as if they're positive. And so this is with triple-dose therapy, zidovudine, lamivudine, and then treatment dosing of nevirapine or raltegravir, and we do that for 6 weeks. Infants who are not high risk, but they also don't fit the strict low risk category, We just do zidovudine, but we do it for a longer time. I think the important thing to remember here is that any baby born to an HIV-positive mom is going to receive some sort of antiretroviral drug, either a single drug, zidovudine, or triple therapy for a really high-risk situation. So what do we do to follow them up? We test them at different time periods because we know that there can be a delay in a positive test. So we test them at birth, 2 to 3 weeks, 1 to 2 months, and 4 to 6 months. If in certain scenarios, for example, if they are breastfeeding, then we will test them more frequently and at later time points than this, depending on when they complete breastfeeding. To do a final test, you can do an antibody screen at 18 to 24 months of age. You do want to obtain a baseline CBC, and depending on the scenario, some experts may choose to follow more closely. You want to counsel all moms, parents against pre-mastication, meaning chewing food for the child before giving it to the child. And then if breastfeeding, provide continued counseling regarding safe breastfeeding. So like we said before, remember, maternal antibody sticks around in those kids for a while. So you don't want to do any kind of an antibody test before 18 months of age. You want to do a DNA or RNA PCR. Okay, if a kiddo is older than 18 to 24 months of age, you can do an antibody test, including the rapid test. That's the antigen/antibody test. And then anybody, regardless of whether it's an infant or not, who has a positive rapid HIV test needs confirmatory testing with a PCR, which is this nucleic acid amplification test. So let's look at survival of HIV-infected children receiving triple antiretroviral therapy. If you ever receive triple therapy, greater than 90% of kids were still alive at 14 years of age. Never received triple therapy, 40% were alive at 14 years of age. So treatment for infants, for babies, for children as soon as possible, and maintaining that treatment and maintaining control is really important for long-term survival. That wraps up the second session of the congenital and perinatal infections. I really enjoyed that, and I look forward for more to come. Thanks so much.